Hello and welcome. My name is Katrin Emery. I'm an NIV specialist physiotherapist, and this teaching is going to cover non-invasive ventilation and type 2 respiratory failure. There are two types of respiratory failure. Type 1, which is a failure of gas exchange, where your oxygen is low, and type 2, which is a ventilatory pump failure. This can be characterised into acute or chronic respiratory failure. In acute respiratory failure, we see a pH which is low or acidotic with a raised CO2. Our oxygen may or may not be affected, and our bicarbonate is within its normal limits. In chronic respiratory failure, our pH has normalised, but our CO2 remains elevated. Our oxygen may or may be affected, but our bicarbonate has raised to show compensation. To understand type 2 respiratory failure, you need to understand how our body regulates our normal CO2. Our CO2 is directly and inversely proportional to the CO2 that our body produces as a waste product divided by our alveolar ventilation. Alveolar ventilation equals our minute ventilation, take away the amount of dead space we have, and our minute ventilation is equal to our respiratory rate times our tidal volume. Breaking down our dead space, there are two types. There's the anatomical dead space, which runs from our pharynx and larynx down to our terminal bronchioles. And then we also have our physiological dead space, which extends beyond that and also includes our alveoli or gas exchanging surfaces. Currently shaded, you can see the anatomical dead space, and coming up we'll see what also includes our physiological dead space being shaded in now. There are three main types of patients at risk of respiratory failure, and the first one we're going to look at is those with airways disease. We typically think of those with obstructive conditions such as COPD or bronchiectasis. We're going to look at how different parts of the equations are affected in each group. In airways disease, the tidal volumes are typically lower because of the scarring and fibrosis of their lung tissue. They also have an increased amount of dead space for several reasons. It may be that their alveoli are full up of exudate or sputum or infection. It could be that their gas exchange surfaces are thicker due to infection or scarring processes, and therefore gas exchange is slower. It could be that their airways are narrower or bronchospastic, or it could be that they've got bullous changes where several of their alveoli have ballooned together to form an emphysematous or bullous sac. These patients may have an increased rest rate to compensate for the reduction of volume and increase of dead space. But what we know about respiratory rate is that it's fatigable. We also know that an increased respiratory rate is often associated with a smaller volume inhaled and a reduction in the time for effective exhalation. Going back to the original equations, we can see that with an increased rest rate but a lower tidal volume, overall our minute ventilation is down. If we combine this with an increase in dead space, then the overall effect of that is that our alveolar ventilation will be impaired. We therefore know that impaired alveolar ventilation is going to be directly associated with an increase in CO2. Another group at risk of respiratory failure is those with neuromuscular disease, such as motor neuron disease. In these patients, the respiratory muscles may become weaker. We know that to inhale, we rely on the movement of our ribs and the depression of our diaphragm to create pressure changes which allow for air to flow into our lungs. If there isn't sufficient muscle strength to move the ribs and depress the diaphragm, then volumes will be reduced. With these patients, respiratory rate and fatigue is a big factor. They tend to have a minimal respiratory reserve once they reach the point of respiratory failure. Their dead space, however, is much the same. Going back to the equations, if our respiratory rate is increased but our volumes are largely reduced, we're going to see a reduction in minute ventilation. Even though our dead space is much the same, this minute ventilation reduction alone will reduce alveolar ventilation, and again we know that that's directly associated with an increased CO2. Finally, we'll have a look at how obesity and obesity-related sleep disordered breathing impacts the chances of type 2 respiratory failure. We can split this group into three phenotypes: our obstructive sleep apnea group, our obesity hypoventilation group, and the combination of the two. Looking at our obstructive sleep apnea group, so we have an upper airway surrounded by tissues and muscles. When we sleep, we get a reduced tone of these muscles, which may reduce the pressure within the airway. If this pressure reduces to a critically low level, then the airway could collapse entirely. How this looks to a patient: if we were monitoring their oxygen saturation, their heart rate, and watching or hearing them sleep, we'd often see that during the normal early phases of sleep, their SATs and their heart rate would be steady and they probably wouldn't be snoring. As their airway changes and the reduction of muscle tone takes place, we see that they might start to snore, but we may or may not see any changes in our SATs or heart rate at this point. As it reaches a point of being critically low and we get complete airway obstruction, that snoring will cease, but we will see a reduction in our oxygen saturation, and along with that we'll eventually see a spike in the heart rate. And that's the heart responding to that low oxygen and going into a fight or flight response. With our obesity hypoventilation group, we're looking at issues that arise from sleep disordered breathing. Sleep involves both your REM and your non-REM sleep stages. REM stands for rapid eye movement, and it occurs every 90 minutes or so and can last about 30 minutes. This is where dreaming takes place. During this phase of sleep, we have reduced muscle activity, where the only muscles that we're using are our diaphragm and our eyes. Because of this, we see a reduction in tidal volume, because using the diaphragm alone will put a greater load on it to be able to shift the excess of weight that sits around the overweight person's thoracic region. If we were to monitor these patients' oxygen saturations and carbon dioxide as they sleep, what we'd see is a gradual reduction in saturations over time as they hypoventilated, and along with this we'd see a gradual increase in carbon dioxide. How this eventually results in type 2 respiratory failure is through the impact on the tidal volume. Because of the increase in adipose tissue around their thoracic cage, we will see a gradual reduction in tidal volume due to the excessive weight on top of them as they're trying to breathe. Going back to the equations, we'll see a reduction in tidal volume, particularly during REM sleep. Potentially an irregular respiratory rate if they've got coexisting OSA, and overall a reduction in minute ventilation. They may or may not have changes with dead space, depending on whether they have any coexisting respiratory disease or whether they have any coexisting heart failure and associated fluid overload. Overall, this affects our alveolar ventilation, and we know now that that results in an increase in carbon dioxide. We'll now go on to look at different types of ventilatory support available. If we didn't intervene with ventilatory support, we'd continue to see a varying respiratory rate and tidal volume. We're therefore not changing any parts of those equations, so we can't expect a change for CO2. We then come on to one form of non-invasive support, which is CPAP. CPAP stands for Continuous Positive Airway Pressure, and involves setting one pressure which is maintained during inspiration and expiration. It acts as a splinting pressure, which is useful in the OSA group for maintaining airway patency. It doesn't, however, impact the tidal volume or the respiratory rate that we know is involved with CO2 control. So so it therefore has a limited role in those with type 2 respiratory failure. We then come on to non-invasive ventilation, or BiPAP. BiPAP involves setting two pressures: an expiratory positive airway pressure, which is maintained through our exhalation, which acts as a sprinting pressure or to overcome the dead space of the machine, and then an inspiratory positive airway pressure, which adds a positive pressure behind every breath taken by the patient. The machine will cycle between these two pressures, often dictated by the patient's effort. This will result in an increase in tidal volume, much above what the patient would achieve without positive pressure support. We also have the ability to add in a backup respiratory rate, which means that we can set a minimum respiratory rate that we want our patient to maintain. Both of these things we know are associated with CO2 control, and therefore have a role to play in those with type 2 respiratory failure. The ventilatory pressures that we set for each patient is very much dependent on the physiology behind their reasoning for needing an IV. We'll go on to look at roughly what settings may be used for different patients with different conditions. Patients with airways disease typically need a low to moderate amount of EPAP. This may be simply to overcome the dead space within the machine, or it may be to match the patient's own levels of intrinsic PEEP. These patients typically have a higher amount of pressure support or a higher IPAP, and that's often depending on the quality of their lung tissue and how restricted this may be. Contrasting these patients are those with neuromuscular disease. These patients typically need a very low level of EPAP, again to overcome the dead space of the machine, and a very low amount of pressure support, as they typically have healthy lungs that expand under pressure. Our obese patients tend to have a much higher level of EPAP to overcome the upper airway resistance to maintain airway patency, and a higher level of IPAP to overcome the weight that sits on top of their chest as they breathe. Finally, we'll come on to looking at intrinsic PEEP. Intrinsic PEEP may be higher in those with airways disease, such as COPD. Intrinsic PEEP is a positive pressure that's maintained within the lungs. This is often characterised by seeing a patient breathing apically with accessory muscle use and appearing quite hyperinflated. They tend to have a higher functional residual capacity and breathe at more of the apices of their lungs with a reluctance to fully exhale. If the EPAP we use with these patients is less than the positive airway pressure that they maintain themselves, we're therefore going to have ventilator asynchrony. We therefore need to try and match our EPAP to the patient's own levels of positive pressure to allow for free flow of air. We can think of intrinsic PEEP and EPAP as a waterfall and a stream. If our patient is breathing at the top of the waterfall and our pressure on the stream below is going against it, that pressure has got to go against the flow and uphill to actually reach the patient and help them breathe. It therefore doesn't work smoothly. We need to increase that stream to the same level as the top of the waterfall to allow for air to flow in the right direction easily.